So Dr. Lazar had to step away, so I'm going to have the privilege of introducing Dr. Carla Boutin. I'm sure she needs no introduction, but she certainly deserves one. So I will do my best. So Dr. Boutin graduated from the State University of New York Downstate. She completed a residency training in internal medicine at the New York Presbyterian Hospital of Weill Cornell Medical Center. After residency, she completed a Master's of Science degree in clinical epidemiology, also at Weill Graduate School of Medical Sciences. As the Associate Dean of Diversity, Education, and Research at SUNY Downstate, Dr. Boutin teaches courses on the health equity and creates programs to increase diversity in the biomedical and physician workforce. She oversees a number of programs that attract students from high school to undergraduate schools to pursue careers in medicine. Dr. Boutin has expertise in community-based participatory research, qualitative research, survey development, and culturally tailoring interventions. She has published peer-reviewed articles on her work. Her research activities focus on identifying the psychological and social determinants of health and on the social epidemiology of health disparities. Dr. Boutin has received funding from the NIH and the Robert Wood Johnson Foundation. She was the first principal investigator and director of the Center of Excellence for Health Disparities and Community Engaged Research at Weill Cornell Medical Center. She served as the chair of the Minority Health Council for New York State Department of Health. She's the co-principal investigator on a Health Career Opportunities Program grant funded to SUNY Downstate from HRSA. She is PI of the NIH-NHLBI funded T32 in translational cardiovascular disease research programs and PI of the 2017 to 19 Empire Clinical Research Investigator Program. She directs the undergraduate summer research program that is supported by an NIH endowment grant translational program of health disparities research training, Transport. She's the co-chair of the Community Engagement Working Group for the NHLBI Jackson Heart Study. She serves as co-director of the Health Equity and Social Justice Work Group at SUNY Downstate College of Medicine as well. So that's a mouthful, but wow, what a career so far. We're so lucky to have her and to have her today. Dr. Boutin.
Thank you so much. And I'm honored, and I'm truly honored to be here. And the lecture by Drs. Jacoby and Jose, that's going to be a tough one to follow. I'm not that humorous, but thank you so much for setting the stage. And you actually, as I was thinking about what you said in terms of laughter is medicine. I started thinking about one of my favorite proverbs that says, a joyful heart is good medicine, but a crushed spirit dries the bones. So this is a very informative talk. So what I'm going to be talking about is on the topic of role modeling, but focusing it on equity. So you can role model professionalism, you can role model humor, we can also role model health equity. So there are no conflicts of interest to disclose. So the objectives of my talk are to provide an overview of key constructs that are relevant to health equity, the importance of role modeling, as a vehicle for promoting equity. And I'm going to provide some examples of how, as medical educators, we can role model equity in practice and share with you some of the work that we're doing here at Downstate. So it's hard to start any talk without reflecting on what we've been through as a community of educators, a community of scientists, of clinicians, of caregivers, you name it. So 2020 fundamentally shifted healthcare, as well as health education. And if we reflect on 2020, it was really a cascade of a confluence of of circumstances and events that included not only a virus, but also the killing of and murder of unarmed Black men and women, the disproportionately higher number of COVID cases and mortality observed in communities of color, the glaring inequities in our healthcare system that was unveiled throughout the pandemic, and even still as we think about vaccine uptake and confidence, as well as an ongoing contentious political debate. So 2020 is definitely one for the history books. And in response to this, there was a rallying outcry against racism. 2020 served as a catalyst for medical students, residents, clinicians, staff across the country to once again unite in activism. It served as a platform for demanding that health systems and academic health centers respond to racism and inequities, not only outside of our doors, but also within healthcare. And we responded, we all responded. Academic medical centers, healthcare systems, local government came together in a unified response that said, we stand in solidarity with you, and declared racism as a public health threat and as a threat to health equity. In 2020, President Biden issued an executive order advancing racial equity and support for underserved communities. In October, the New York City Board of Health joined over 200 other agencies across the United States, again, declaring that racism is a public health crisis and calling upon hospitals and academic medical centers to work together. In December, our governor declared that New York State declared racism was a public health crisis. The AAMC under Dr. David Scorton and the Chief Diversity Officer, Diversity and Inclusion Officer, Dr. David Acosta, wrote a statement in which they said, as leaders of anchor institutions in our communities, academic medicine's physicians, educators, hospital leaders, faculty, researchers, learners, and staff must lead by example and take bold action in partnership with communities that we serve. And we must move from rhetoric to action to eliminate the inequities in our healthcare, research, and education of tomorrow's doctors. So we do have a role to play in advancing health equity in our practice. And as hospital, health system, health educator leaders, equity should really be our top priority. And in 2021, the Institute for Healthcare Improvement conducted an online survey of about 500 US-based hospital leaders, largely clinical industry leaders, about their perspectives on how do you advance equity within the healthcare system, and also to identify barriers. And this included chiefs of service, VPs, managers, quality and safety officers, clinicians, nurses, physicians, and nurse practitioners. So there were 58% of the respondents polled identified health equity as one of the top 3 priorities for their organization. But those that did not, of those who responded that health equity was not a top 3 priority, these are some of the things that they said. My organization does not experience deep or persistent disparities related to characteristics such as race, ethnicity, language, sexual orientation, or geographic location. And we must ask, well, how are they defining disparities and who are they asking? 19% said focusing on other priorities will have a greater positive impact on patients. And again, this is a missed opportunity to really understand how much health inequities impact all aspects of healthcare, healthcare safety, cost, satisfaction, as well as the learners, right? Their learning environment. Another 18% said, my organization does not currently have the right leaders in place to drive the work of health equity, which says that we do need more training. And as leaders in academic medicine, we definitely need more training to advance equity. So some other things, my organization has developed a health equity strategy that it is delivering on and has now moved on. And it's important to realize that Equity is not a momentary response to a crisis, that it is an ongoing effort. And it goes on, so there are other reasons why organizations felt that equity wasn't a priority. So I'll read one more. My organization does not have the funding to commit to health equity work. Well, not doing so is costly. A study by the Kellogg Foundation found that racial inequities costs contribute to about 93 billion in excess medical care, whether it's direct care or lost productivity. And also inequities contribute to other things such as job dissatisfaction, attrition, as well as people just leaving their jobs, and that's costly. So there is a cost to not prioritizing health equity. Okay. So what are some of the gaps? We need a better definition of what equity is, how to measure it. We need better frameworks. We need more practical guidelines on actual steps that we can take as healthcare professionals and leaders and educators that's at little to no cost. And we need training. We definitely need training in medical education. So I'll start out with a definition. Health inequities are differences in access, treatment, outcomes between individuals across populations that are systemic, avoidable, predictable, and unjust. And for healthcare system, healthcare equity is achieved. So that was health inequities are the differences. Healthcare equity is achieved when everyone, every individual in our healthcare system has the opportunity to achieve full potential. For patients, it may be full health potential. For our learners, it's opportunities for leadership, resources, staff, it may be salary and promotion, job satisfaction, safety and well-being. So health equity occurs when we have systems in place where everyone can at least have a chance of working toward attaining their full potential, and where no one is disadvantaged based on social positions or socially determined circumstances. So these are some of the frameworks that I like to think of when we talk about equity. And these frameworks can help to anchor and direct us in how do we role model equity. And this framework includes focusing our lens on anti-racism, structural competency, intersectionality, and trauma-informed care. So racism, this is a topic that we don't like to discuss, but we have to. We really have to. If we don't, then we miss the opportunity to identify fundamental cause. So I like this definition by Dr. Kamara Jones. She calls racism a system of structuring opportunity, assigning value based on social interpretation or how one looks. It unfairly disadvantages or unfairly advantages other groups, and it saps the strength out of the whole society through a waste of human resources. Structural racism, more focused, is the macro level systems, social forces, institutions, ideologies, and processes that interact with one another to generate and reinforce inequities. Such as discriminatory policies and laws that create differential access to goods and services and opportunities. And this differential access is what contributes to health inequities. And the thing about structural racism is that it's pervasive and it lasts long after those who created the ideologies and the policies have moved on. The practices still exist within the institution. So that's why we must be intentional about this. And an anti-racism framework, it doesn't say that you're racist or I'm racist. It talks about the system, and it's not simply saying I am not a racist, but it's understanding that racism exists and questioning ourselves. Well, how is it operating here? How is racism or discrimination or bias? How is it operating here? And developing organized strategies to address it collaboratively and to look for opportunities. Undoing racism is really looking for opportunities for everyone to contribute to health equity. Structural competency is a framework that was developed by Jonathan Metzl and Helena Hansen. And this was a framework that's applied to clinical care, but it can also be applied to research and medical education. And basically it says it's the ability to analyze and recognize and respond to structural barriers that have been created and that sustain inequities and that perpetuate structural racism. So it's recognizing systems and structures that shape our clinical interactions. It's using an extra clinical language around structure. It talks about re-articulating presentations in terms of structural terms and imagining an intervention that's based on changing the structure and developing structural humility. So basically, structural competency is seeing a problem and not saying, this problem is because this person is. So saying COVID, Blacks are more likely to die of COVID. And by saying that, it focuses on Blacks without necessarily understanding the structures that are in place, and it limits intervention. But if we were to say, there are structural barriers that limit access to healthcare, there are historical and current policies that discriminate against meaningful and limit meaningful access to care. There's structures and barriers that created food deserts and food insecurity, and all of those things converge to create a situation where you do have disparities in an outcome. That's what structural competency is, but that takes work. Right? Just like making good jokes, that takes work as well. And we just have to be thoughtful about it. Intersectionality is basically acknowledging that people have different and unique identities, and they sometimes converge and coexist in the same person, but they can also be different spheres for opportunities for discrimination and oppression. And that's another lens for us to see who we are. So some examples of how vulnerabilities are created. And as medical educators, we often talk about the vulnerable population, the vulnerable patient. And we have to think about that. That person in and of themselves is not vulnerable just because they are. What are the structures that are in place that perpetuated structural racism that creates these vulnerabilities? Because otherwise we will try to fix the individual and not address the system, whether it's addressing our older aging population, immigrants, LGBTQ+ community, the disability community, justice involved, rural communities, medically underserved community, and so forth. We have to understand what are some of the systems that are in place. And it is so important that when we're speaking to our learners, that's the language that we use to recognize that it's not these vulnerable people, but what are the systems that are in place that create vulnerabilities? And trauma-informed care basically is a program of organizing a system where we realize trauma has been done, we recognize signs and symptoms, we respond by integrating full knowledge about what's happened, and we seek not to re-traumatize or not to cause pain. And we can do this, use these frameworks as a way of moving beyond standing in solidarity to take bold, sustainable, and intentional steps toward promoting health equity. So, role modeling. We are all role models, excuse me. And we've been hearing about role modeling this morning. So role modeling, according to Dr. Bandura, much of learning occurs through modeling, the process of acquiring new information through observations. And in medical education, role modeling is the process by which physician educators demonstrate skills, model, and articulate expertise, expert thought processes, and motivate positive professional characteristics in learners. The process is not they see us and they do what we do, but our learners will see us, they see us do something, we must call attention to it. And sometimes I guess that's what humor does. It calls attention to something, but if it's hurtful or cynical or derogatory, we've drawn their attention to something that we don't want them to emulate. So as educators, we must think about how do we draw attention to what we want our learners to actually do. what are things that we can do to help them retain information? Because learners create cognitive schema that enables them to retain and recall. What are opportunities for them to reproduce and replicate what they've observed? You know, perhaps taking a patient history in front of us, and how do we motivate them to continue to practice these lifelong ethos of medicine, and how do we reinforce these behaviors? So role modeling and the hidden curriculum often coincide, as we've heard about the hidden curriculum, and it's a powerful socialization process that takes place beyond the classroom, and it's through observations and interactions. Role models can play a significant role in the hidden curriculum and influence professional identity, personal growth, and career choice. And oftentimes I hear from students, I never thought about this. I never thought about being a neurologist, a pediatrician, an endocrinologist, a cardiologist, a psychiatrist, but I had this mentor and I saw the way they interacted with the patients, and I saw and they made the patients feel good, and I want to do that. So role modeling is very powerful. And role modeling is also a vehicle for promoting equity beyond focusing on professionalism. It can reinforce the attributes and place a premium and prioritize equity and social justice. And it's also an opportunity for us to move beyond making pronouncements of solidarity to practice, and move beyond theory to practice. So REACT, this is a framework that it's in press. The article should come out in the fall, and it's going to be published in Medical Teacher, and it's called REACT, a framework for role modeling anti-racism in the clinical learning environment. And this is based on a review of the literature, prior work that's been done in this area, and it proposes incremental and an iterative process that form the acronym REACT. Reflect, educate, assess, call out, and to treat all members with respect and value. So reflect. We have to start by reflecting on our own biases. We all have biases. It's a social cognitive process. That's how we learn. That's how we live. That's how we went through graduate school, by making associations and putting things together. We all have unconscious biases. These are automatic thoughts and unintentional, but nevertheless, they pass judgment and they influence our medical decision. And as Dr. Jacoby and Jose said, it can manifest during times of stress. It can manifest as ill-placed humor or misplaced humor. So according to social cognitive research, stereotypes are used to make sense of the world. We assign values based on one's skin color, and unconscious bias has been linked to our decisions about whether or not to refer someone to cardiac cath, pain treatment, making psychiatric diagnoses, birthing experiences, and the use of medical procedures. So the E is to educate. So we have to so after reflecting, we have to educate ourselves and to understand how policies contribute to social determinants in health. So really understanding the root causes of disparities, whether it's in surgery or psychiatric care, making a diagnosis of severe psychiatric disorders, as well as maternal fetal morbidity and mortality in birthing people of color. So it's really educating ourselves on why are these disparities, why do they exist? And so A is to assess and examine the use of race-based practices. We've been hearing a lot about the use of race in the EGFR algorithm. So even saying something as Asian patients are considered at risk for diabetes at a lower BMI. This has been promulgated in the medical literature. It begs the question, who do we mean? Like, what do we mean by Asian, and what is this based on? So there's a whole host of algorithms and treatment decisions that we make on race that's really not scientifically sound. And we also have to call out racism. So that's the C. So it's calling out racism when we hear it, when we see it, calling attention to policies. And we can do so in a way that's reflective, that brings people together, and that generates more communication. And as Dr. Jacobson-Dickman always says, we have to be upstanders and be willing to speak out and take action in support of, not in defense of, but in support of those who are harmed. And our words, our words, we've been talking about words. Our words are important. How we speak about our patients and how we see our patients, how we describe our patients are living with rather the suffering person, and how we treat people in the ways that demonstrate their lives matter without necessarily saying anything, using appropriate pronouns, asking, how may I address you? The way in which we speak about our peers is really important without necessarily making derogatory comments about a patient or in the presence of a patient. But when we talk about each other, when we talk about our peers and our colleagues, what are we saying to our learners when they hear us talk about and make disparaging comments about people in the profession? So when speaking about colleagues, whether we're in the classroom or in the cafeteria, we must be aware of what we're saying. The clinical notes, so reviewing our clinical notes is another way of making sure that we're treating everyone with respect. So clinical chart review have found language that uses stereotypes that blatantly express disapproval of patient decisions or describing the patient as difficult. We write this in our notes. Our learners are reading this. They're learning that it is okay to make these comments in a legal medical document, and that's not what we want. So we have to be careful and thoughtful about how we are describing our patients in a way that can be used to make medical decisions. Saying that the patient was difficult does not help you with the diagnosis. So language audits of educational material is important, and calling attention to what our learners are documenting. So if someone writes something to say, oh, I noticed that you wrote that, this patient refuses to take their medicine, this patient has been consistently, and this patient is argumentative, let's talk about that, right? Because you're signing their notes. Without saying anything, that means you've basically co-signed and agreed with them on what they said. So use this as an opportunity. We can also role model equity through quality improvement. A lot of our residents and students are doing QI work, and there is no quality without equity. So as we're doing research with our students, we're trying to promote what the Institute of Medicine talks about as quality, the degree to which health services for individuals and populations increase the likelihood of a desired outcome. And the Institute of Medicine outlines 6 areas of qualities: patient safety, provide care that is effective, patient-centered, timely, efficient, and equitable. All of that really points to equity. So we can do QI work through equity as well. So this is the DMAIC 5-step improvement model for Six Sigma and LEAD. And I am not a Six Sigma expert at all. So please do not ask me questions because I won't know. I'll just send you to Dr. Lazar. I'm like, I don't know. But I thought that this was really helpful in thinking about what steps can we do to role model equity in our QI projects by defining, measuring, analyzing, improving, and controlling. So this model says defining the problem, naming racism and discrimination when we're talking about health inequities, collecting data. It is so important that we collect and disaggregate race, ethnicity, and look at intersectionality and put race where it belongs, not in the chief complaint, right? It is not a biological factor. It is important to collect these data so we can see if differences exist, where and opportunities, but it's not in the chief complaint. Also analyzing data from a structural lens. If we're seeing that there are patients who are having challenges or a particular health condition is prevalent in one population, to ask ourselves, why is that? What are some shared experiences that they may have? And then take steps to improve by changing policies and understanding current and past trauma. And then make plans. Control is making plans to monitor, sustain accountability, and involving our community partners. Encourage equity leadership and scholarship. So our learners want to write, they want to publish. So writing papers, writing letters to the editor, writing up what you heard here today, doing that from an equity lens, acknowledging support of those who are involved in diversity leadership, and encouraging all faculty to be involved, not only the faculty who identify as belonging to a specific race or ethnic group, but everyone should participate in this. And then when our learners see that, wow, we have this attending who is talking about diversity and racism. It's not only, something that our Black faculty are doing, our Latinx faculty are doing, all faculty are doing. We have a faculty who's talking about Asian hate and violence against our Asian community. Wow, this is something that all of our faculty are interested in. And it creates this collaborative workforce partnership. And students will want to join us. The conferences that we have, who are we inviting to grand rounds? What do they look like? So these are all of the things that we can do to really elevate health equity as an important aspect of our mission. These are some of the things that we're doing at Downstate. The dean has prioritized health equity as a priority in the strategic plan. That is really important because it says that someone, top leadership thinks that this is important. We've established a health equity work group. It involves clinicians, faculty, the dean, everyone is involved. We've involved students and community partners. We're conducting focus group with our patients. We want to hear what our patients are saying and using these to go back and to educate our learners. And we're forums such as this. So thank you, Dr. Jacobson-Dickman, for putting this together, where we're creating a space to have conversations and to have discussions and to understand that we're not perfect. We will make mistakes, but just as our learners are learning, so are we. And so I'd like to end with this quote by Dr. Kirch, the president emeritus of the AAMC. He says, leaders in academic medicine must confront racism and inequity and work together to create a culture that exemplifies our commitment to diversity, inclusion, and equity. So thank you so much for being here. And if you have any questions or thank you.
I just wonder, what you've seen that you're hopeful about in all of this.
Was my talk hopeless?
Yeah, no.
See,
but
right there. No, what am I hopeful about? Oh my goodness, our students are amazing. Our students are asking us to elevate what we do. I am so hopeful that the mistakes that I made, that we made, that our students will not allow these mistakes to be made, that our students are calling us out, that our students are challenging us to think about things in a different way. Because of our students, I've read things that I never would have read. I stopped saying things that I never thought about that was hurtful. So I am extremely hopeful about our learners, that they're creating a space where, even though we don't talk about racism, we don't talk about bias, because that's not what we learned in med school or grad school. There wasn't a place for a discussion about these topics when we were here, right? Dr. Jacoby many years ago, but there is a space for that. So I'm really hopeful that together we can really make a difference. So that's what I'm hopeful about. Hi there, Dr. Kurt.
Hi, Carla. Thank you for this wonderful and illuminating talk. I'm wondering, have any of the named people here run into hotspots of pushback or resistance to the policies you're enunciating? I'm not asking you for names and departments and so forth, but are there departments, are there occupational groups, house staff or senior faculty where you get more pushback than you ought to be getting?
Well, the answer to that is yes. It's because whenever you try to make change, you will meet opposition. And I don't think it's individuals who are intentionally saying this is wrong, we shouldn't be doing this, but they may not understand the value and the importance, and they may see it as this isn't science. Why are we teaching this in our medical school? So it's from well-intentioned individuals who may not necessarily see this as a place for having these conversations. So that's sort of the pushback, the gentle pushback that I've observed. I've yet to come across anyone who says, absolutely, you cannot do this, but it's more of, why are we doing this? Why are we talking about this? Let's get back to real medicine. So those are some of the pushback that we have to say, no, this is important. But thank you for that question, Dr. Kurtz.
Hi, Carla. Is this on now? Okay. I was wondering, we've been kind of looking for a practical, what can we do to practically help with this? I was wondering if we have written down anywhere practical advice on how to set up a PBL case or a formative question or, a pop scenario so that we talk about the person, the person walks in with the complaint, but what kind of wording, like example of good way to do it would be helpful.
This is a great question. Yes, our colleagues at the University of Syracuse, Amy Caruso Brown, developed what's called the Bias and Inclusive Checklist that provides some steps on how we can create questions. And this is what we're going to be launching this year, where we will ask our educators to look at the lectures that you're writing and to rethink how something should be said or can be said. So they say, do you have pictures in your lecture? Yes. What are the pictures of? Do they present someone in a way that's dehumanizing? For instance, the bar across someone's face or showing one's genitalia. Do you have permission for these pictures? Do you mention race? If so, in what way? Do you talk about someone with a disability? If so, how do you present them? So yes, I can share those as a matter of fact. We will be sharing that, but thank you very much. There are some guidelines that can help steer us and guide us in the right direction. Okay. Thank you very much.